Hi, my name is Mathur. I'm an orthopedic spine surgeon at Cary Orthopaedics. I specialize in minimally invasive spine surgery. Today I'm going to discuss a minimally invasive treatment for compression fractures called a kyphoplasty. Kyphoplasty has really changed how we treat compression fractures. In the past, if you had a compression fracture, we would treat it with bed rest for several weeks and then treat you in a brace. However, now we have a new technique that we do where we place cement into the bone, which allows you to be mobilized that day of surgery. We usually do the procedure in our office, and it normally takes anywhere from 20 to 30 minutes to do the procedure. After the procedure is done, most people have a significant improvement in their back pain. When we think about compression fractures and the reason why we get compression fractures, there's two or three primary reasons. The first and most common reason is as everybody gets older, they get osteoporosis. The second reason is if you have cancer and there's invasion into the bone, which can weaken the bone and cause a compression fracture. And the third category is called secondary osteoporosis, meaning that if you have endocrine problems or if you're on long-term steroids, that can weaken the bone and lead to compression fractures. I'm going to discuss the most common cause of compression fractures, which is osteoporosis. So here you can see what a normal bone looks like. It looks like a square, and when there's a compression fracture, it looks like a wedge where the anterior part of the vertebral body is compressed down. The most common areas where you get compression fractures are in the lower part of the lumbar spine or in the thoracic spine where the ribs are. I'm going to show you a picture of a healthy vertebral bone and then compare that to what happens when there's osteoporosis. As you can see here, this is the inside of the vertebral body, which we call cancellous bone. And cancellous bone has pores, which are these areas where there are holes, and these holes are connected to each other by this bone, which is called a lattice network, which are interconnections. So the more interconnections you have between each of these holes, the stronger the bone is. So this is a young, healthy person with what their bone looks like. And now we're going to contrast that to what bone looks like when you have osteoporosis. When you have osteoporosis, you can see that the holes are bigger, the porosity is more, and there's less interconnections between each of these holes in the bone, which means that this is weaker. So when you fall or even sneeze, you can get fractures that occur through this area of the bone that can lead to a significant amount of pain. I'm going to discuss a procedure called a kyphoplasty, and this is a minimally invasive technique in how we treat these compression fractures. Just as a review, this is a vertebral body, and when it's compressed, you can see how it turns into this wedge structure. You can see the fracture lines that have occurred through this vertebral body, and the micromotion between these fracture fragments leads to a significant amount of pain. The procedure is done under MAC anesthesia. What that means is that we give you a small amount of anesthesia through your IV. We have an anesthesiologist who performs the anesthesia. Basically, you're lying on your stomach. We use X-ray to identify the broken vertebral body. We use something called biplanar fluoroscopy, which means that we can look at the vertebrae in three-dimensional anatomy. Once we've identified the vertebral body that's broken, a small needle is placed under X-ray guidance into the area where the vertebral body is broken. This is done through a very small incision. This is what a picture of the three-dimensional X-ray looks like, where you can see the needle as it enters the broken vertebral body. Once we've identified that we're in the correct region, the needle is then removed. Through this needle, we're able to put a balloon catheter, and we inflate the balloon catheter. And as you can see, by inflating the balloon catheter, we're able to reestablish the height of the vertebral body, and this assumes a normal height compared to the other vertebrae above and below it. Once we are able to achieve the proper height by expanding the balloon, we then deflate the balloon, and we remove it through the same needle that we placed the balloon. After the balloon is deflated, you can see that there's a cavity now that we've created with the balloon, and the goal is that the cement that we place inside will remain within this cavity and will not go in any other direction. And this is what we call a negative kind of pressure area that will limit how far the cement goes. The next step is to place the cement into this area and to fill this cavity. The cement takes about 20 to 24 minutes to solidify, and once it does, it provides stability to this broken region in the vertebrae, and there should be a significant amount of improvement. The needle is then removed, and we apply a small Band-Aid to the incision, and the patient is then taken to the recovery room.
Hi, I'm Melissa. I'm a registered nurse here at Cary Orthopaedics Spine Specialist. I'm with Dr. Mathur. I'm one of his nurses here. And next time you come in to see us for your last appointment prior to surgery, I'll be speaking with you about your spinal procedure. In the following slides, you will learn about spine surgery education, the risks, recovery, and frequently asked questions. First off, we have the general risks of spine surgery. These risks are quoted with our own office with Dr. Mathur, usually less than a 1% chance. We have infection, bleeding, paralysis, blood clots, persistent pain, dural tear, and anesthesia complications. A dural tear is a nick in a spinal cord sac that the spinal cord lives in, almost like a water balloon. If that is punctured in surgery, typically we can see that happen. Fluid leaks out, cerebral spinal fluid, and it is then given a patch during the surgery. That would keep you overnight. We would monitor you and watch it the next day. That is actually the highest risk on this list. Again, it is probably less than a 1 to 2% chance within our office here with Dr. Mathur, giving them all a low percentage rate. So we have some questions that are very standard here. Anytime we have people come in for spine surgery, we put the top 10 together. So here is that list. When can I drive? We definitely prefer you don't drive until after your first post-operative appointment. That's usually because of pain medications, possible weakness before surgery that lingers after surgery, and just your strength in general. Position for sleeping is always on your back or your side. If it's a cervical surgery, a neck surgery, we want you on your back or your side still, but then we also want you elevated. That will help reduce the swelling. Some people do actually require a brace for surgery. It's going to depend on the surgery itself and the mechanism of your surgery. Will I be in pain after surgery? Yes, you will be in pain after surgery. Typically at the incision site is most common. Sometimes residual pain from your prior symptoms are still present as well. We hope that there is some relief immediately, but that's not always the case. Returning to work is very different for everybody. It's going to depend on which exact surgery you're having and then also the job requirements pertaining to it. Do I need supplies for my incision? Yes, you will need supplies. So most commonly you're going to need gauze and tape. Each incision is just covered with gauze and tape when you leave the hospital, and you actually won't change that incision until your first shower, and which is the next question, which is standardly about 3 days. If you would look at that on the slide, it says you may also use Tegaderm with gauze. Tegaderm is a fancy type of tape that a lot of doctors use. We like to use it as well. It's a great use of tape. It can be expensive, so if you can find it at a reasonable price, it is worth getting. Also, island dressings. Island dressings are great as well because it comes with the gauze already attached. It looks like a big white Band-Aid. We talked about the showering. We do prefer 3 days. Some cases you'll have to wait 5 days, but we would talk specifically with you at your appointment about that. You do need to change your dressing, but only at shower day. So at day 3, you will take a shower, take your bandage off first, take your first shower, and then put a clean dressing on after that with your supplies that you had bought previously. When can I be intimate with my partner? Generally, we suggest about 6 weeks. Will I need physical therapy? In most cases, yes. Again, this is one of those questions that is just going to be pertinent to your specific surgery and recovery. These are specific risks regarding the kyphoplasty procedure: adjacent segment fracture, persistent pain, cement embolism, cement extravasation. These risks here are very low with Dr. Mathur and his staff. We have seen less than 1% for all of these. This is not a bed rest procedure. It's also not a high activity procedure. We encourage walking as tolerated and position changes, but at the same time, in those first few days after the procedure, you really aren't doing too much. You will be experiencing some soreness around that incision site. That sharp bone pain that you're experiencing now should be resolved, but you will have lingering muscle pain and muscle tightness around those incisions. So you won't be incredibly active right after surgery, but we definitely don't want you in bed all the time either. Sitting up, watching TV, walking around the house, getting out of the house is even fine as well. If you had a back brace prior to this procedure, you no longer need to wear it. You may use ice to help with the pain right over the incisions, but please no heat. Most commonly, pain will occur at the incision site. No driving until you come back for your first follow-up appointment. You can shower 2 days after surgery. You'll have internal stitches and little band-aids covering up your incisions. They are very small. If those band-aids fall off, that's absolutely no problem, even if it is before your 2-day shower. Shower 2 days after surgery, and then please no lifting greater than 5 to 10 pounds until you come back and see us. Preparing for surgery. Dr. Mathur and or his highly trained staff is always available to assist with your questions or concerns. You can find that information on the website on how to contact us. You will have one last appointment prior to surgery. This is an appointment devoted to educating you with Dr. Mathur and his nursing staff. We will provide further information about your specific surgery and recovery. This is the perfect appointment to bring your questions and your caregiver to. Surgery can be intimidating, so please let us know if we can assist you in any way on making this a smoother process. And for further information, please visit www.mathurspinesurgery.com and then follow the links below.